Shall we start?
Yes, we're
Yes,
ready.
yes.
Good evening, colleagues. I am Dr. Arvind. On behalf of Emcure Pharma, I would like to welcome each one of you for today's academic feast on the evolving role of Cidofovir, Meet the Expert. At Emcure Pharma, we are really proud to bring innovative, affordable, and high-quality medicine such as Cidnavir, Cidofovir injection for the better management of your patients. In addition to this, we are also committed to bring cutting-edge scientific program with stimulating discussions, which will enrich your scientific information, and it will be benefiting to the entire medical fraternity. For today's program, it is my pleasure and honor to introduce our moderator, Dr. Vikram Mathews, sir. He is a well-known and respected figure in the area of hematology. Dr. Vikram Mathews, sir, is currently the Associate Director, Professor of Hematology, Department of Hematology at Christian Medical College, Vellore. With this, now I hand over today's program to Dr. Vikram Mathews, sir. Over to you.
Good evening, everyone. Thank you, Dr. Arvind, and thank you, MPO, for this opportunity. Today's talk is really, as a disclosure upfront, is sponsored by MPO, but it's really going to be as much scientific as possible and to talk about, of course, they brought about Cidofovir as a generic drug, and that's something that's useful for us. We'll also use this opportunity to discuss with the experts in the field, and I'm very grateful to Dr. Francis Marty for coming on at a very short notice. I'll introduce him in detail when his talk comes up. The overview of this session will be basically Dr. Biju was supposed to be here. Unfortunately, he had kind of an emergency at home and had to travel, and so he could not make it today. So I'm going to try and do his slides, and I'm never going to do as good a job as he is. He really handles all the infection problems in our transplant program, and it would have been great if he was here. It's unfortunate that he couldn't be here today, and I'll try to go through his slides and give you a sense of our own data. And this will be followed by a talk by Dr. Francisco Marty, who's the Associate Professor of Medicine at Harvard Medical School, Dana-Farber Cancer Institute at Boston. He's a familiar figure in India, and he's very actively involved in all the Indus PMT educational programs, and we're always grateful to him. He always gives us very practical insights on how to handle many of these very complex infection problems in the post-transplant setting. We also have with us a set of panelists. We will have the two talks in series without any interruption. And we have with us Dr. Dharma Chaudhary, and most of them are very familiar to this audience. Dr. Dharma Chaudhary is at BL Kapoor. Dr. Sharad is the clinical director at Narayan Hridayalaya in Bangalore. Dr. Ganesh Jateshwar is the consultant hematologist at Yashoda Hospital in Hyderabad. Dr. Kashi Vishwanathan is the director of transplant at Meenakshi Mission. Dr. Neeraj is from Amrita. And Dr. Mamta Manglani is the director of comprehensive thalassemia care at Mumbai. Thank you all for coming on again at fairly short notice. And with that, I'm going to start. The flow will be that after the two talks, we will open it out for questions, and the panelists and Professor Francisco Marty will kind of weigh in on the discussions and give them both a local feel and also an international perspective on state of the art in the management of viral infections, especially in the context of CMV. So with this, I'm going to request the people who are handling the slide to allow me to share my slides. Can you allow me to share my slides, please?
Yes, sir. Yes, sir.
Okay.
Yes.
Okay, just give me 1 minute. Okay, can you see my slides?
Yes, sir. Yes.
Okay, okay. Zoheb, are you there?
Yes, sir. Yes, sir.
Okay. So I'm going to do this talk in behalf of Dr. Biju, who could not be here. So I'm going to talk a little bit about viral infections post-transplant. The majority of the audience I know are transplant physicians, and I'm going to go through a few basics because I've also been told that there is quite a bit of students out there in the audience. So as most of you all know, a stem cell transplantation is a process by which conceptually any genetic or acquired disorder in the hematopoietic stem cell can be corrected by transplanting from a potential donor. And usually this involves taking a patient through chemotherapy and radiotherapy, ablating the bone marrow, infusing cells from a donor who does not have that particular problem. And usually we do have a well patient. But during that entire process of chemotherapy and radiotherapy, there is a fair amount of ablation of the bone marrow. And these are the classical stages of reconstitution following an allogeneic transplant. You have the pre-transplant phase, you have an engraftment period, and what you're seeing over here is the neutrophil counts in the patient goes to a very low level, and it takes about 2 weeks to 3 weeks at times to return. Then there's the early post-engraftment, and usually when we talk about engraftment, we focus on platelets and neutrophils. There's an early post-engraftment and there's late post-engraftment. And what a lot of attention is not often given, especially from a student perspective, is that while we focus on the neutrophil engraftment, it's important to remember there's a whole set of innate and adaptive immune system that has to recover post-transplantation. So the NK cells recover fairly rapidly. In our own published data, by day 28, you get almost pre-transplant normal levels of NK cells. But the T cells and B cells can have prolonged low levels, and the inverted CD4 to CD8 ratio can persist for up to a year post-transplant. So based on these parameters, we know that different types of infections come out at different times. So during the early engraftment period, when there's mucosal damage and neutropenia down, you're often looking at bacterial infections, HSV, and in the post-engraftment period, where there is viral reconstitution yet to fully happen, a number of viral infections can come on. HSV infection persists. CMV infection usually comes on from the early post-engraftment period around day 28. Day 14 to day 28 onwards is when we start looking at an increase in CMV infections. So at Velo, we did our first transplant way back in 1986, then the first autolog was 1922, a haplo in 2003, first mud in 2008, and the haplo-identical PTCY from 2010. At present, we do about 250 to 300 transplants a year. And you can see in 2019 of 230, there are increasingly more and more complex transplants being done, including 96 haplo and 27 muds. And that's the split up of the type of transplants that we do. Third is hemoglobinopathies. Another third, aplastics, and most of the others are malignant disorders. So if you look at our data in the pre-haplo, pre-mud era up to 2001, and this is data that we published on 304 transplants, that was the breakup of viral, bacterial, and fungal infections. Surprisingly, tuberculosis is fairly low, and viral, mainly CMV, was seen in about 22% of patients in that series. Again, this is a series of patients where there was practically all matched sibling donor transplants. Viju has put this data together of a more recent cohort, and this period involves much more complicated transplants, mismatched transplants, unrelated donor transplants, haploidentical transplants, use of fludarabine, more use of anti-thymocyte globulins. Again, you can see over here that sibling donor transplants are about 1,660, haplos about 248, and muds about 236. Viral infections in this series, about 519 recipients, 35.4 patients had, 35.4% had viral infections, mainly CMV, BK, and respiratory viruses. As all of you all know, in CMV, there's a high seroprevalence in India with 95, 98% of the population being seropositive, in contrast to about 38 to 75% in the West. And the patient and the donor serological status remains the most important cause of CMV viremia in a Western population. And this is fairly old data by Lungman et al., which shows you the association. So if both the donor and the recipient are negative, the incidence of CMV reactivation is very low, as seen by the orange graph, figure line over here. While if the recipient is positive, the reactivation is fairly high. However, in India, you can see that recipient and donor are positive in practically the majority. 84% of patients will be both recipient and donor positive. So the recipient negative, donor negative component is an extremely rare population, rare group of transplants in our setting. And CMV reactivation occurred in 36.3% of this population. The median time to CMV reactivation was 41 days. And here you can see in different types of settings, the amount of CMV reactivation. All of us recognize that with acute GVHD and treatment for acute GVHD, we have greater reactivation, 59.4%. With PTCY, it goes up to 64.4%. And it goes up to studying 72.7% when we have a haploidentical donor. So truly, with the increased use of haploidentical donors, we are seeing this problem much more. And our own data of patients who have CMV reactivation versus those that don't have shows a significant inferior survival in those that did have CMV reactivation. Cost of management of CMV, this has been a challenge. We've really not had much generics in this area. Ganciclovir costs about 50,000 for a course. Foscarnet about 4,50,000. And Cidofovir, one dose costs about $2,000. And that's something that we now have a generic which MCure has brought out. In CMC, we've also started viral-specific cytotoxic T cells. This is a platform where basically you take cells from the donor, you expose them to a catch matrix reagent, in this case it's CMC PEP mix, and then you pull out the interferon gamma positive cells, and we do this in-house. We've standardized this, and the QC is going as has been established. This just shows you a positive control and CD8 positive cells with interferon gamma positive. And this is actually a donor with CMV PEP mix stimulation showing you the CMV interferon gamma positive, a small proportion of cells. And this is a particular patient where the donor was a haplodonor, where the donor mother and father had both screened. And you can see this father had a better proportion of cells that reacted to the CMV PEP mix in vitro, and therefore he was chosen as the donor. He had a CD8 interferon gamma positive percentage of 3.34%, so we chose him as the donor. And this procedure, we infused our first patient with CMV CTL just 11th of June 2020. How do we identify high-risk populations? We look at haploidentical HSCT, match unrelated donor HSCT. Donor HSCT with GVHD are high risk for CMV reactivation. And another study that we are interested in is looking at CD45 depleted, RA positive depleted donor lymphocyte infusions prophylactically in high-risk patients. Within the autologous transplants, it's important to remember that patients who have received bortezomib as prior therapy have a higher risk of CMV reactivation compared to those that did not. BK virus has been another real difficult problem for us, especially as we do more mismatched transplants and haplotransplants. It's more the morbidity that patients go through with this particular disease. And this is another disease where we have used Cidofovir. So the data is not exactly impressive with Cidofovir in BK virus. And really, both medical therapies are not very effective. The pathophysiology essentially is that BK virus targets the uroepithelium, and this targeting of the uroepithelium is more when there's conditioning causing damage of the uroepithelium, along with immunosuppression, allows the BK virus to proliferate, causing epithelial damage, and the alloimmune response often aggravates this epithelial damage. And BK viruria occurs in about 50% of patients after BMT. The incidence of BK viruria is similar in allogenic and autologous, but hemorrhagic cystitis occurs in only about 20 to 25% of BMT recipients. And we monitor the urinary BK viruria copy numbers, and usually above 10 to the power of 10 copy numbers is where you see most of your hemorrhagic cystitis, though that's not an absolute. Our own data, 1,276 transplants, that's data put together by Biju. Looking at 262 had hemorrhagic cystitis, 189 were checked for BK viruria by qualitative PCR, 105 tested positive for BK viruria. And really, this major problem is our MUDs and our haplotransplants, where up to 13.3% have frank hemorrhagic cystitis. So most patients would have asymptomatic BK viruria, for which you really don't need to do anything. But once they become hemorrhagic cystitis, for the most part, it is supportive, so we do use Cidofovir at times. I'd conclude by saying viral infections are a major problem in patients undergoing HSCT. There's a higher incidence in alternate donor transplants and following GVHD. CMV is the major cause of infection, followed by BK virus and respiratory viral infections. I've really not touched on respiratory viral infections in detail. We see a fair number now that we have a full panel to identify them, but the ones that really give us problems is H1N1. And of course, we have no experience with COVID. We've not had a patient with COVID at this point in time who picked this up post-transplant. Various therapeutic strategies are available, but some limited by finances. There's significant role for viral cytotoxic T lymphocytes, both in CMV and in BK viruria. I'm going to stop here, and I'm going to straight away hand it back to the organizers to get Dr. Francisco Marty to go ahead with his presentation. And after that, we will have the question and answer session.
Okay. I'll share my screen.
I've already introduced Dr. Francisco Marty, but just for those who joined in late, Dr. Francisco Marty is Associate Professor of Medicine at Harvard Medical School, Dana-Farber Cancer Center Institute in Boston, Massachusetts. He's been very actively involved with us, and he's come here for multiple training programs. He's been part of the Indus BMT educational setup, and we are very grateful to him for having been with us and also coming on at such a short notice. Over to you, Dr. Francisco.
Cool. Okay. Can you see the slides?
Yes, sir.
Yes.
Oh, good. All righty. So thank you for the invitation. It's an interesting question, so I thought it was also good for me to kind of put my thoughts together and go a little bit further in my knowledge and of the history of Cidofovir and how he's been used. So we're going to be talking about medical stuff and a lot of off-label use. So just warning you, and these are my disclosures, mostly for research and consulting. So we're going to talk about different things. So a brief history of Cidofovir. Sorry. How do we give it, which is very important to minimize toxicity. And then we'll talk about the use in cytomegalovirus, other herpes viruses, for adenovirus diseases. Well, see if it's good for BK polyoma. I have my opinion on that. And then we'll talk about other viruses or viral-related illnesses for which Cidofovir is used with success. So the history of Cidofovir begins in 1986 when Antonin Holy, who was a Czech, he died in 2012, a Czech chemist, and Eric Leclerc started working together. Leclerc was a microbiologist, virologist who was working on animal models of vaccinia and smallpox and herpes viruses. And Anthony Holy had this, developed these phosphonyl methoxyprolyl compounds. And then this was the first one that they found. They published that in Nature in 1986. And then the following year, they studied different compounds that had the same kind of tail of phosphonyl methoxyalkyl derivatives. And the one that you see there, HPMPC, or the cytosine analog, was the one that was the most potent and the one they thought would be the most useful. And that's Cidofovir. It is a nucleotide analog, and it inhibits the viral DNA polymerase, okay? As opposed to ganciclovir and acyclovir, it doesn't need a viral thymidine kinase, but it just uses the cellular enzyme, so that's one difference. And it has quote unquote broad spectrum of activity against DNA viruses, right? This is in vitro, doesn't necessarily means that it's active in vivo. All the herpes viruses, for adenoviruses, for pox viruses, for human papilloma viruses, and polyoma viruses. It was approved in 1996 for the treatment of age-related cytomegalovirus retinitis, and that's the only approved indication anywhere in the world. One important thing about Cidofovir is that it enters into cells by concentration gradient, mostly. That's why we give it as a quick infusion, so that we can generate that concentration gradient so that the molecule can enter into the cells. There's a little bit of fluid phase endocytosis, but it's a minor component. All right, so it's passive diffusion gradient. It is excreted in the proximal renal tubules by the organic ion transported 1, okay? And that's what leads to the renal toxicity. It accumulates in the tubules or concentrates in the tubules and leads to cellular tubular injury and nephrotoxicity, okay? And then the other thing, and that's the reason we use probenecid, because probenecid blocks that transporter, and we use intense IV hydration protocols to reduce this risk. So this is how we give cidofovir with this schedule. We can give it to transplant patients, non-transplant patients, and the risk of nephrotoxicity probably in the 20% or less. All right, so as you can see, we start by giving 2 grams of probenecid, and then we give the normal saline. Nowadays, we're using also Ringer's lactate, but normal saline is what was used in the trials and this traditional solution. We give 500 cc's an hour for 3 hours, so it's intense. Then we give cidofovir 5 milligrams per kilogram over 60 minutes, and we follow that by a liter an hour for 2 hours. I put 999 because most pumps don't have 1,000, so you just have to use the 999. And then we give another gram of probenecid, and then 6 hours later, we give another gram. When we do this as an outpatient, which we do sometimes, we make sure that the patient has probenecid to take at home 6 hours after they go home. Okay, otherwise, increase their risk of toxicity. These are the trials that led to the approval of cidofovir in the US back in 1996. They were published in early 1997. And basically, there were 2 trials. This one led by Lalesari, where an induction of 5 milligrams per kilogram per week for 2 weeks and maintenance show delay or non-progression of CMV retinitis compared with people that just had expected or delayed therapy. And then there was an 8 trial group trial comparing 2 maintenance doses, showing that the 5 milligram per kilogram every other week was better than the 3 milligrams per kilogram every other week. So basically it's 5 and 5, and followed by 5 what we should be using. All right, and then the use in bone marrow transplantation, there was a case report in 1999 that was the first use. And then in 2001, several reports came out with experience from different people. This experience from the URTC, and you can still see that 20 years later, Per Youngman and Catherine Cournier still kind of have the lead on these type of infectious disease papers in Europe. So basically, it was a collection of cases treated in Europe for CMV pneumonia, other CMV diseases, preemptive therapy, either secondary or primary. And as you can see, there is a response rate, but it's not great, right? So it's 56% for pneumonia, 25% for other diseases, and then, a response for secondary preventive therapy, but a failure in a fair amount of patients, okay? Another case series from England. Again, they used it in 4 patients. 2 responded, 2 didn't respond, and then 1 that responded didn't recur, and the other one did recur. Just to show you in kind of in a diagrammatic perspective how these drugs works, right? So you have ganciclovir, you need the UL97 and the thymidine kinase if you're talking about HSV or VCV, and then you have several kinases that make the triphosphate, and then they bind to the polymerase and cause the chain termination. With cidofovir, you don't need to use, so it's independent of the UL97, so you can use it for ganciclovir-resistant infections that are based on UL97. Problem is that if you have an alteration in the DNA polymerase binding site, you could have resistance to both ganciclovir and cidofovir, okay? And foscarnet just binds directly to the polymerase, so it has a different type of mutations or mutational profile that leads to resistance. Sometimes you can have viruses or CMV viruses that are resistant to the 3 of them. What I would say is that at least the even though there is no randomized trials with cidofovir itself, I think the most useful use of cidofovir is for adenoviral diseases in transplant patients, both solid organ and bone marrow. It is off-label, and basically, it's been shown several times that if you treat earlier, these patients, they tend to survive. There's adenovirus disease, as we can kind of test, can be very quickly, can move fast, and can be from diagnosis to death, can occur within a week if you're not doing surveillance in high-risk populations. So, and I'm going to bring cidofovir not because it's been developed, but because it has an important story regarding the use of cidofovir for BK virus. Right, so cidofovir was developed as a lipid conjugate of cidofovir, right? And basically, the two things is that the phospholipid allowed it to be transferring to the intracellular space better, like a phospholipid. So therefore, it's much more potent than cidofovir. And because of that lipid tail, it's not an organic ion transporter 1 substrate, so it's not nephrotoxic. But those limiting GI toxicity led to failure in the phase 3 trial. Right, this is data from the phase 2 trial that we led that showed that 100 milligrams twice weekly was improved CMV viremia significantly compared with placebo. But in the phase 3 trial was a negative trial. The primary endpoint was at 24 weeks. There was less CMV, but there was more death without CMV on the treatment arm. There was a toxicity that was mostly GI toxicity that was confused or confounded as GVHD. Right, and what I wanted to show is that this is the antiviral activity against CMV. Right, so there was an antiviral activity, but then because of GVHD, there was no significant difference at 24 weeks. Okay. Because of the toxicity and because of the negative finding, the drug was not pursued, the oral formulation. What I wanted to show is that because everybody knew that cidofovir and brincidofovir were, broad spectrum antivirals, there was a pre-specified secondary endpoint on BK disease, right? So all these patients had prospectively collected samples, and all these patients every week during treatment and every follow-up, they were asked about GU symptoms. And if they had GU symptoms, they were tested again for BK virus. And what you can see here with a drug that's 100 to 400% more potent than cidofovir, in a placebo-controlled trial, double-blind, there was no impact of brincidofovir on the incidence of BK. If anything, because of the GVHD fooling of doctors, the incidence of brincidofovir associated and the incidence of BK clinical disease was actually higher in the brincidofovir arm, even though it was not statistically significant. Right. So after I saw this data, in the past I used to use cidofovir for patients with severe BK, but we were never sure if it worked or not. But after this, we stopped doing this at the Dana-Farber and the Brigham, because having a drug that's more potent than cidofovir, has a higher intracellular concentrations, there was no signal as a prophylactic of preventing BK disease. So one of my takes is that I no longer use cidofovir for BK disease. So what else is cidofovir used in bone marrow transplant patients? Well, one is topically for cutaneous herpes simplex that's resistant to acyclovir. This is the first report from 1994, from the Clerk's group, showing that they gave topical cidofovir, leading to resolution in somebody who was acyclovir and foscarnet resistance. Right. One thing that's important about when you use cidofovir systemically is for, let's say, for adenovirus or CMV, is that you could see herpes simplex reactivation in this context. They're not necessarily resistant So what we now do is, if we're using cidofovir, especially for herpes simplex, and especially the first few weeks before you go to steady state, we continue a Iclear prophylaxis in these patients. Another, we had published this in Transplant ID, but I had forgotten about it. But there is this report about using cidofovir oral rinse solution, not a cream for topical application, but an oral rinse. And this group at MD Anderson used it twice a day, like a switch and spit. And it was very effective in controlling oral herpes simplex. And one thing that they point in the paper is that the labial ulcer that was not exposed to the suspension, because it was meant for oral administration, got worse, whereas everything else looked better. As we said, it's active against papilloma viruses, and topical cidofovir has been used for treatment of recalcitrant warts when other treatments are not successful in transplant patients. There's one example. This is another example that's more extensive. I thought was interesting, right? That you could say this is a chronic GVHD or a chronic situation, but really was on biopsy verruca or warts. Okay. And then there's this interesting cutaneous disease called trichodysplasia spinulosa, which is now confirmed to be caused by a polyoma virus, right? And that is also response to topical cidofovir. Here are 2 cases, and there are several cases reported in the literature. When you see this type of rash, just think about trichodysplasia spinulosa and using topical cidofovir for these patients. And then now the case report level is patients with ORF. In immunocompetent patients, it's a self-limited disease, but this is a case of ORF that the lesions were, I didn't show you the whole sequence here, but the lesion kept growing after 6 weeks of diagnosis, right? So usually should have resolved by a month. So given this, they decided to use topical cidofovir, and that led to resolution. So how do I use cidofovir in 2020? I think it's my go-to drug for adenoviral diseases. We have no access to bring cidofovir anymore. So for adenovirus disease, we use it preemptively in patients at high risk with rising adenovirus levels. So who are these patients at Dana-Farber these days? Cord blood patients, patients who get T-cell depletion. Those will be the top groups. We don't routinely screen people with haploidentical transplants, but we will do syndromatic screening rate. Somebody comes with fevers, somebody comes with hepatitis, somebody comes with diarrhea, somebody comes with pneumonia or respiratory illness. We always look for adenovirus. Okay, and then we use the adenovirus blood load to re-stratify patients, and if they have significant disease and the virus load is more than 10,000 or 100,000, depending on that risk, we will treat them with cidofovir. And then in that situation, we will continue weekly until the disease has resolved and the virus load has negativized. Sometimes when we go to maintenance every other week, we see the infection recrudesce. So this is a way we use cidofovir every week, even beyond week 2. Okay. Sometimes if we have renal dysfunction or if it goes away and then there is relapse, sometimes we'll do it like every 10 days, like a Monday and a Thursday on alternate weeks. So again, that's our tricks that we use here in Boston. For cytomegalovirus, before we had access to letermovir and the trials with marivir, we used to use it as a step-down therapy for toxicity to other agents, especially people with a lot of myelosuppression. We would use it as a step-down therapy, but we would wait. At the beginning, we used to give it liberally, but we will see a lot of failures. So basically, nowadays, we wait until the virus load is below 1,000 before we consider it, and even better if it's below 500. And we will use it as secondary prophylaxis in patients at high risk of recurrences and disease. if other options for prophylaxis are not available, right? So sometimes we will do very high doses of Iclear. Sometimes we will do Cidofovir for secondary prophylaxis. And again, in here we expect a 25 to 30% failure rate, even with these conditions. So we continue monitoring. I think for HSV is a good systemic therapy if the isolate is resistant and you have multifocal disease or systemic disease. This is rare, but we use it frequently for topical therapy for localized disease, in the lips or perianal area. And as I said, we no longer use it for BK-associated diseases. So I guess the take-home point is that I don't always treat viral infections with Cidofovir, but when I do, I always use 5 milligrams per kilogram. There are a lot of papers using 1 or 3, I think from the randomized trials and from just understanding of the drug. When you use a lower concentration of the drug, you're not getting it into the cells. You're not generating that concentration gradient. So you're just treating yourself and wasting the drug. So even in renal failure, we've had patients even with kidney transplants with allograft nephritis with adenovirus. We use 5 milligrams per kilogram up front and patients recover. So just as an important point here. And I just want to thank you for the invitation and for being with you there in India from being here in Boston at the same time.
Okay, thank you so much, Marty. That was a great talk and a great overview. I think that sets up the template for some questions. Again, I just want to introduce the panelists we have with us. These are all busy physicians, many of them administrators. I'm sure they all have busy on multiple fronts besides just their clinical work. And so grateful to all of them for taking time off and attending. There's Dr. Dharma Chaudhary here, the senior consultant at BLK New Delhi. Dr. Sharad, who's the clinical director at Narayan Hridayalaya in Bangalore. Dr. Ganesha, the consultant hematologist at Yashoda in Hyderabad. Dr. Kashi Vishwanathan, who heads the department at Meenakshi Mission. Dr. Neeraj, who heads the department at Amrita. And Dr. Mamta Manglani, who's the director of comprehensive thalassemia care. So what I'm going to do in the next 15-20 minutes is direct a few questions at the panelists. The objective is mainly to as educational for the students and others who are listening on different platforms to this talk. And I also encourage the panelists to actually direct questions to Professor Francisco Marty to clarify, because we have lots of issues, and a lot of access issues with many drugs, etc. So I really wanted, I would like the panelists to take the lead and control of the discussion as and when required. To just start it off, I'll just ask Professor Francisco Marty a few questions, and then I'll open it and direct it to other people. Francisco, you talked about not reducing the dose of Cidofovir. So there's a common practice, I would say, I'm not sure I could say it's a common practice, but one option that people think about is don't use probenecid and use a lower dose of Cidofovir. And this is something we sometimes think about doing when we are trying to cut the costs of the drug. Is there any rationale for that?
Just, as you can see, the drug gets into the cells by passive concentration gradient. So if you don't generate the concentration gradient, you're not going to treat anything, right?
Okay.
So if you think about it, when you're doing the 1 milligram per kilogram without probenecid, what you're doing is dumping the Cidofovir in the urine because you're letting it be excreted in the tubule. So the only exception would be theoretically if you had a tubular adenovirus disease, you had adenovirus nephritis. But if that could give you a higher concentration, but if you're treating pneumonia, if you're treating encephalitis, if you're treating any non-kidney disease, you're just not doing anything, right? So, okay. And even for adenovirus nephritis, we prefer to use a 5 milligrams per kilogram and use the probenecid, because that way you get a systemic concentration of the drug. And again, these are viruses like you can isolate in multiple, for adenovirus, for example, and CMV, right? These are systemic diseases, right? For a lot of these patients. So So I really, I know it's a lot of publications, but I just wanted to be very clear that if you're going to use it, use the full dose, otherwise don't use it.
Okay. So just one last question, because it came from the chat. What about when people have significant cytopenias or renal failure? How would you go about dosing? At what point would you say I would not use Cidofovir?
With cytopenias, there is no issue because, even though it was described as a side effect in the trials in the 80s with, in the 90s with in HIV patients, we don't see much neutropenia in the bone marrow transplant patients in which we use Cidofovir as a treatment for adenovirus or CMV. So the only question is renal failure, and that's a judgment call. So for CMV, we do have alternatives. As you said, you can even do third-party T cells. We have access to maribavir. We have letermovir. So thankfully, we have alternatives. For adenovirus, I would always use 5 milligrams per kilogram independent of the renal function because it's a lethal disease in our patients if we let it go. So it's a risk-benefit assessment.
Okay, thank you. Okay, Dharma, just to understand, can you just walk us through your CMV monitoring strategy post-transplantation, very broadly?
Yeah, so we do weekly PCRs now. We use the COVAS Roche platform.
Okay.
And basically, again, if we see virus loads are going up steadily, we start preemptive therapy. People at high risk now, we're using letermovir prophylaxis. The people with standard risk, who are not T-cell depleted on courts, we're still doing preemption. And then we also, after the 100 days, we do, if patients have acute GVHD, we continue surveillance. If patients don't have acute GVHD, then we go to a syndromatic approach, right? So people, if they come sick with anything, then we screen for CMV as part of the evaluation.
Okay, thank you. Thank you, Francis. I'll just move to Dharma. Dharma, what would be your strategy for CMV monitoring?
Hi, good evening, and thanks, Marty. Is very nice talk. So what we do at our center, like those patients who are matched sibling donor transplant after engraftment, we monitor initially weekly and then put on fortnightly monitoring, and the copies number those who goes more than 1,000, then we start preemptive therapy. So those patients who are high risk, particularly haplo and mud, we are monitoring very closely weekly, and even we intervene if the copies number going more than 5,500, and then we start putting them as a preemptive therapy. So the rigorous monitoring for haplo transplant, the mud transplant, and patients who are on graft versus host disease. So before starting the immunosuppressant, we send CMV for every patient. At least we are starting steroid-based therapy. So and we monitor up to 100 days very closely, and haplo and the mud up to 180 days. At least fortnightly, even they don't have the GVHD or additional immunosuppressive therapy.
Okay, thanks, Dharma. I think so. Everybody got that, both from Francisco and Dharma. Hey, Sharad, how are you? Just moving on to you. I just want to just to walk us through, Sharad, and I'm sure Francisco can pitch in. We all have these patients who have, we start ganciclovir for rising CMV copy numbers. 2 weeks down the line, the copy numbers are still high. We're still spiking fever. We can't find any other cause. And in India, we have limited options. How do you approach that problem?
Yeah, I think from our end, if I can just start on that, it is certainly a worry when you see the copies kind of not settling down, but you still kind of pursue with the full dose of ganciclovir. We just give it a little longer time frame, and we've seen some patients settle down just with continuing the same full dose of ganciclovir. We have issues of, I think, cytopenia and even the renal failure and renal toxicity come up, and sometimes that forces us to dose adjust. It's in that setting where sometimes when we are stuck and we have progression on that, we have to consider the alternative of either foscarnet or cidofovir, and that's when we bring this up. So that's
how do you choose, Sharad? How do you decide, because this is always, there's never, 5 fellows in CMC, every fellow has a different opinion, So should we use foscarnet? Should we use cidofovir? We have limited options. So is there any way that you go about it?
Yeah, no, I think there's no real algorithm here, Vikram, to be honest. I think a lot of it's finances, availability, which decides it. From a very practical perspective, that's what we do.
Right. Foscarnet is expensive for us, Francisco. I mean, so that's often a challenge for us. But in an ideal world, with rising copy numbers and, essentially drug resistance to Ganesha, what's your go-to drug, Francisco?
So I think, you have the kind of the first comment is the I'm blanking on his name, the group, the Emery and, the London group's kind of quick rule, which is you're allowed to, because the replication of CMV is on the way up, or is an exponential replication, even with effective therapy, in the center of GVHD, you expect a 1 log and a half increase in the first 2 weeks, right? So if you start at 1,000, you're allowed to go up to 15,000, 20,000 by 2 weeks, and that virus won't be resistant. You just have to sit tight, right? Okay, so that's an important thing.
So that's an important point. I want to stress, Francisco, I'm so sorry, because I think a lot of people don't realize this here. And there's often a tendency to jump and change drugs,
Exactly.
So that's an important point. So you're saying at 2 weeks, if you see rise with GVHD, don't react, just continue the drug.
Yeah, so basically, and it's a very good practical rule, right? So, and we're talking the logarithm phase, right? Let's say you start at 5,000, right? I don't know if you start everybody in-house or you just use the Valsite outpatient, but sometimes you start, even if you start Valsite as an outpatient, it may take a day or 2 or 3 for the patient to get the drug. You have to factor that in when the patient actually started taking the drug.
No, for us, it's instant. Here, that's not a problem,
Okay, anyway, so you start at 5,000, that patient can go to 50,000 in 2 weeks, and we don't change anything, right? So you tolerate up to 1 log, technically it's 1 log and a half, right? And actually, if you look at all the trials that we're doing now for resistant CMV, they say, no, you don't drop by a log in 2 weeks, right? So it's only in week 3 that you start being concerned with resistance, right?
So day 21. Day 21, if it's not coming down, you're concerned.
Exactly. That's when we do the switch.
Okay.
Or if you have clinical disease, right? Or if you go beyond the 1 log, right? That 5,000 patient is 100,000 on week 2. It's okay. This is too much. It's 2 log increase.
Got it. Also, and when you go for switch, what's your switch?
So we go to foscarnet. And what we do that, again, is not clear in the books, is remember that antivirals work not by peaking, as opposed to cidofovir, that you need the peak to get into the cells. Foscarnet gets into the cells very easily. So it's more like a penicillin. You just want to stay above the IC90, right? Okay. And then basically what we do is we always start with 60 milligrams per kilogram every 8 hours. We never do, we stopped doing the
90
hours probably 12, 15 years ago, because that's where we used to see a lot of renal failure.
Just say that again, Francisco. You stopped doing what?
The 90 milligrams per kilogram twice a day.
So you stopped doing that.
We don't do that up front. We always start with 60 every 8 hours. Then that makes sure that we don't get peak levels. We infuse it over 2 hours. 1.5, 2 hours. So you don't get the peak levels, because that's what causes the tubular injury in foscarnet. And then with that, we are able to control the infection without minimizing the risk of renal dysfunction, right? So a rate of renal dysfunction with that approach is probably 20% if patients have normal renal function at baseline.
And what's the role of cidofovir?
Q12.
What's the role of cidofovir then?
So as I mentioned, for cidofovir, we use it on the way down. Let's say somebody you have control with ganciclovir or valganciclovir, but then counts are very low. The patient clears, but let's say somebody with grade 3 GVHD, or somebody who had a cord or just had a haplo and got ATG, or so he's going to reactivate again. Okay. So before letermovir, it was very common to put those patients on cidofovir for secondary prophylaxis.
Okay.
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 Because you could give it in the clinic when they come to clinic, right? So use it as a tail end. Somebody's 200-300 copies. It's already on the way down. We would use it in that sense.
Sure.
Knowing that you're going to have a 20-30% chance of the virus breaking through.
Okay. Thanks. Okay. We'll go to Dr. Ganesh. I hope he's on the. He's there. Of course. Hi, Ganesh.
Hi,
Ganesh, I'm just trying to understand in your haplo program, how much of BK virus problems do you have, and how do you approach it in terms of management?
As you have enumerated in your talks, BK virus related hemorrhagic cystitis or BK virus reactivation, in fact, is more common. But BK virus hemorrhagic cystitis manifesting clinically, grade 1 to 3, is also somewhere in the range of 15 to 20% in haplotransplant program. So essentially, not having the effective antivirals across our management is mostly supportive bladder irrigation, GCSF bladder irrigation, simple saline bladder irrigation, fluoroquinolones, and supportive care. This is all tranexamic acid, sometimes bladder irrigation when there is grade 2, grade 3 hemorrhagic cystitis. So it's essentially supportive care.
Okay.
And I just one of the patients, Fanconi's anemia post-haplo, having a grade 3, grade 4 hemorrhagic cystitis refractory to the persistent severe hemorrhagic cystitis symptomatic patient was literally screaming, used to scream all through. So that we use cidofovir, but I'm not sure how effective it was. My personal feeling is it just took 3 months and it resolved on its own, continued supportive care.
Okay. Thanks. I'm just going to move it back to Francisco. Francisco, what do you think is the role of quinolones in BK virus, either preemptive or as therapy?
I mean, it's like hydroxychloroquine for COVID. We have more and more stories showing that it doesn't work, but people keep using it.
Yeah,
right?
yeah.
So,
we use it. I can tell you we use it because we're often pushed to a corner. So we use quinolones, we use cidofovir. We all know that, they probably recover on their own. So you don't feel there's any role?
There's placebo-controlled trials, both for prevention and for treatment or preemptive therapy, both in bone marrow transplants and in kidney transplants that show no more side effects. You get more tendonitis, tendon rupture, C. diff. So really, there are multiple trials, probably 4 or 5 now. Actually, one of my research assistants is putting together kind of a summary of all the randomized trials showing that both in the prophylactic setting and in the preemptive therapy setting and the treatment, there is no benefit, right? So one of these things that, somebody went off the handle and then, people keep doing that. So I think it is a major concern. We're motivated enough that we're doing a natural history study, with our group to understand the disease. Because if you think about it, we don't even have a autopsy or pathology study of BK in bone marrow transplants there, because the kidneys get biopsy. We understand kidney disease in kidney transplant patients, but we don't really even understand what's happening at the pathologic level for BK. So it's a big gap, it's a big knowledge gap. And I think now with better treatments for CMV and prophylaxis for CMV it's become the most obvious, viral disease in transplantation. But I think we have to be humble enough to say, we need to understand this better. They're gonna, I think once we understand the disease and the natural history better, there's only one paper that's mostly in kids that came out early this year or late last year from a group in Philadelphia about the natural history of BK in children, but because it was done by kidney doctors, it focuses on the kidney, doesn't focus on the bladder or the hemorrhagic cystitis. So we hope that in the studies that we're doing, we're really trying to understand the symptoms. We're creating symptom scores, quality of life, to understand what's the morbidity of the disease, kind of so we can go on and then develop treatments. People are looking into T cells, third-party T cells. People are looking into monoclonal antibodies. But we need to move beyond the quinolones and cidofovir for this one.
Sir, Vikram sir, can I also ask?
No, absolutely. Please feel free to ask.
Yeah, sir, to Professor Francisco. So we use a lot of leflunomide as a kind of not scientifically proven, but as a prophylaxis, particularly in haploidentical transplant for BK virus hemorrhagic cystitis, as well as an anti-inflammatory agent, just like we use for patients with chronic GVHD, HCQS. So what role this leflunomide has in BK virus hemorrhagic cystitis? And also the second point was there is some literature coming up mostly from Professor Mathews' group that the post-transplant cyclophosphamide, rather than being given on day 3, day 4, if we space it on day 3 and day 5 and give a gap of 1 day, so does it decrease the incidence of the PTCY related hemorrhagic cystitis in the various alternative donor transplant setting?
Yeah, so I mean, I think one thing that I think we need to clarify is that when my sense is that the incidence of BK disease in haplos is different if you use a myeloablative regimen than a reduced intensity regimen. So what we're seeing is that most of the severe diseases in myeloablative strategies. Second, I think leflunomide, I think it's like the zinc, or I think it's probably an anti-inflammatory. So in that sense, it's decreasing the symptoms, but I don't think it has any impacts on the virus itself. And I would propose to you guys, you guys could do that, a randomized control, placebo-controlled trial of leflunomide, but my sense is that it doesn't help the virology. It may help the symptoms, but it's kind of an expensive and toxic therapy. You do have a fair amount of liver toxicity and cytopenia, so which is something you don't like in haplos, especially at the beginning. So it'd be a very hard sell, at least for me and from people in my team here at the Fiber, to do prophylactic leflunomide in haplos that may have a hard time with counts to begin with, and a lot of CMV early on.
Okay. Thank you. Sorry, please go ahead.
No, you said that I don't think it helps, and some people seem to improve faster, but I wonder if because it's an anti-inflammatory, right? Like we use it in rheumatology,
right.
So
right.
Maybe that's what we're seeing a clinical effect in some patients, but my sense is it doesn't help that much, and you have to deal with the toxicities, which are not, not problematic in the sense of transplantation, because liver abnormalities and low counts is something you don't like to have in early bone marrow transplantation.
Sure. Okay, we go to Dr. Mamta Manglani. Thank you, ma'am, for being here. This is, can you tell us your challenges with CMV in thalassemia in a setup that you're handling, with how difficult is it to monitor and intervene?
So basically, we are also monitoring in match sibling very sparingly, as Dr. Dharma said. But if it is a MUD or a haplo, which we are not doing for thalassemia right now, it would be prudent to do it much more frequently. We've not had great challenges except in a couple of patients where we had GI gut symptoms, and there was one patient who had CMV positive as well as had GVHD-like phenomena. So it was a big challenge how to balance the immunosuppression versus the treatment for CMV. But we managed with ganciclovir and put him on valaganciclovir afterwards, and he did well. He came out of it, and he's doing very well now. He's 2 years post BMT.
Right.
So it's not been a major challenge because we are focusing more on match sibling donors. Yeah.
Fair enough, ma'am. Thanks. Kashi, I can see you still have your COVID beard. It's not gone yet. How are you? And just to touch with you on BK virus challenges that you have in terms of managing BK virus in Madurai. Your voice, you're muted. Somebody will have to unmute.
Am I audible,
okay.
sir?
Yeah, right now you're audible. You are muted so long. Okay.
So BK virus we manage symptomatically with hydration and analgesics. We try to reduce the immunosuppression, and then even though Cidofovir doesn't work, we tend to give Cidofovir for these patients. And mainly supportive care is what we do, sir.
Yeah.
It's not only in haplotransplant we face this Cidofovir. We have it in unrelated donor transplant very rarely also.
Okay. Okay. So there was a question actually in the chat box, Francisco, and I think you'll agree with the statement. Practically, BK virus is supportive. All the drugs that we have, really nothing works. Probably the only thing that works is the viral CTLs, which many of us may not have access to at this point in time. Is that a fair statement to make?
Even the CTLs, we don't know, right? There's this data from the Baylor group, but they use a funny definition of refractory, and then, you know, the median time to improvement was 6 weeks. Okay. And we know that these patients take, 4 to 6 weeks to get better. So we don't even know. And the problem is that we have a big gap in terms of understanding the natural history of the disease, right? So we got to do our homework about the natural history.
Yeah.
And I will encourage some of you guys to work on that, like especially the malablative haplos.
Yeah. Francisco, most of us try to cut the immunosuppression.
But if you think about it, we don't even understand, what makes a patient asymptomatic versus symptomatic, right? They have very high virus loads in the urine and in the blood, and some people just live with it for a couple of months, it goes away, and they never got sick from it. And other people are writhing in pain or bleeding.
Yeah.
What's the difference?
Right.
We don't understand that yet. We don't even, right? So things are obvious to us.
Yeah.
Right? It's an interesting thing because we went from not understanding what was going on to virus load, and we skipped the anatomic pathology and the physiopathology and the immunology of this. So very little knowledge. We need to really invest on this because it's a common problem. It is a common problem. I'm not saying there is not a problem. It's just that, we're like DMB in the 70s. We need to study it in the 80s and start, making steady progress. Yeah.
Sure. Dharma, you are asking something.
I was asking, since we don't have other than Ganciclovir, till this now Cidofovir will be available, or we have through gray market the Cidofovir. So once those who are copies 1.5 logs is going up, or 2 logs going on Ganciclovir.
You're talking about CMV, Dharma, or you're talking about CMV?
I'm talking about CMV.
Okay. Back to CMV. Okay.
So is there any data? We have not experienced to combine Cidofovir and Ganciclovir if one drug is not working.
Well, if you think about it, they tend to bind in the same place. So the UL.
Don't know. I don't know.
Yeah. So basically, if you have combining them proactively to see if there is synergy, there is no synergy. Okay. And then if you're suspecting resistance, adding it on doesn't really help. And you really need, depending on the mutation on the virus, if it's a UL97, Cidofovir will work. But if it's at the binding site in the polymerase, a UL54 mutation, it may be resistant to both. So in that day 21, when the virus is not coming down and you do an empirical switch to foscarnet, we get a genotype at that moment. Okay. So in a week or so, sometimes, even those people who went up or more than a log, they're going to have a susceptible virus, right? And then you can scale back down. You don't have to commit them to a longer term foscarnet. So that genotype is worth the cost.
Worth the cost. Okay, got it.
Vikram sir, can I ask one more thing?
Please go ahead.
With regard to BK viral hemorrhagic cystitis, Professor Francisco, what do you monitor? Whether it is blood BK viral load or urine BK viral, because urinary BK viral load is always going to be high even after recovery. So,
well, we're not monitoring anybody because it's a high noise to signal ratio and we have no treatment, right? So in the natural history study, we're checking for the virus, weekly for the first month and then monthly afterwards, unless they have symptoms, or we examine them for other reasons. But it's mostly to make a diagnosis, right? So if somebody has dysuria or hemorrhagic cystitis, we look for BK, but we also look for adenovirus. So even though adenovirus is less frequent, it's much more aggressive, and Cidofovir will work in that setting, right? And these are people who are going to be very brisk, very quick. They get sick very fast. So for those patients with adenovirus hemorrhagic cystitis, and we see a few cases a year, Cidofovir will work and help them out. And then basically so we raise a syndromatic approach, right? You have this hemorrhagic cystitis and you say, is this adeno or BK, right? Or even for symptomatic cystitis, I say, well, this patient is in a lot of pain or a lot of frequency, right? Remember that both adenovirus and BK, they like the whole of the urothelium, right? So you can have hemorrhagic urethral disease, right? Or inflammation in the urethra, people coming with obstruction, right? Or they have pain on urination. They have urethritis, right? They don't have cystitis, right? So, because sometimes in several cases, especially in men, they say, what hurts? It hurts is the penis when they pee, and it's not the bladder. So just to remember, of course, people talk about nephritis, and that's rare in the bone marrow transplant population, but urethritis leading to bleeding and blockage of the urethra and acute renal failure in that setting is we see maybe once a year, and then urethral disease is also possible.
Okay. So I think one of the questions, Francisco, that Ganesh was trying to address was, would you monitor urine BK or would you insist on blood BK? Say you knew it was BK hemorrhagic cystitis.
Yeah. So, we usually send both once you have a diagnosis to stage people, because if you have a high urine load and a negative blood load, means that the burden of the disease is low.
Okay.
It helps you prognosticate a little bit. Okay. Although the opposite is not true. You can have people with high virus loads in the urine and the blood and be asymptomatic.
Okay. Okay. So we don't have a real defined strategy as such. So I'm just going to go. We are running a little bit short on time. I'm going to go to Neeraj. Neeraj, is Neeraj there?
Yes, sir.
Hey, Neeraj. Hi, how are you? Okay. So, Neeraj, there's a lot of morbidity with BK virus, and all of us struggle with patients where we have this, every day you do rounds, the guys in severe distress. How do you manage symptomatology in your BK virus hemorrhagic cystitis?
Yes, sir. So as you rightly said, it's often a nightmare to manage the hemorrhagic cystitis and other symptomatology with BK virus. So a lot of good hydration, analgesia, and we often have to take, and basically it's this is often very painful, and so we often have to give opioids, etc., for the pain control. And sometimes most often we take the help of a urologist, surgical specialist too, because there are clots inside the bladder, and that often may have to be irrigated. So bladder irrigation is a continuous bladder irrigation is one of the things that we may have to do, and till and this may have to be continued for days and sometimes weeks together. More intensive surgical procedure we haven't done, but I know some you lay open the bladder in very severe cases. Yeah.
Okay, thanks. I think we have 5 minutes more. I'm just going to open it out to all the panelists, and we have Francisco with us. Very grateful again, Francisco, for sparing your time. So we can use this opportunity to ask questions directly of challenges that you meet, and I'm sure that will be an educational exercise for all the people listening on the platform. Let's start with Dr. Mamta Manglani.
Yeah.
Go ahead, ma'am.
So thank you, Vikram. So my question I actually put on the chat also. Do you modulate the immunosuppression in a patient if the CMV does not get better after 2 to 3 weeks?
Yeah. So again, you don't do it in isolation, right? So a lot of these patients do have GVHD, so the oncologists and the BMT doctors will try to lower the immunosuppression. You descale faster if you can, right? So sometimes you can, and that's part of the tricky part, right? So if you can reduce immunosuppression, we do. Especially we try to get rid of, mycophenolate and the prednisone. I think those are the major offenders. You can keep tacrolimus, sirolimus seems to be helpful. And then the other thing that we've noticed and we published about dasatinib for when they're using it for maintenance therapy in ALL patients, we've seen CMV events in people who shouldn't have, like people who are 6 months out, no GVHD, and suddenly they come with CMV, and it's people who are on dasatinib. Yeah, but the general study is yes, decreased according to the overall situation of the patient, and we do tend to go faster.
Okay, thanks.
Thank you.
Anybody else? Just one question, because everybody's asking this, Francisco. There's a lot of use of artesunate in India for CMV. There's a lot of questions on the chat box. What's your thoughts on artesunate and CMV?
I haven't used it. And again, I haven't had a need for it. I guess the question would be, you guys are in a position to do a randomized trial and answer the question.
Okay. Okay. So,
Vikram,
any more questions? Yeah, please go ahead, Sharath. Please go ahead. Please go ahead.
Professor Marty. Yeah. So I was just wanting to ask on the, adenovirus infection. Sometimes we see it as a very bad hepatitis manifesting, or sometimes even associated with hepatitis. And you told us about, using the viral titer, of 10,000 or 100,000. So we've seen that initially when we do treat with cidofovir, it comes down and sometimes it's negative, but there is persistent ongoing hepatitis in spite of that. So what's the plan to either taper off, or how do you come down or continue treatment once you started this?
So you're saying that you have access to PCR, to quantitative PCR?
Yes.
Okay, and then it becomes negative.
Yes.
Yeah. So again, depends on what the situation was. Usually we continue treatment even when the titer is negative for a few more weeks. When you have ongoing hepatitis, again, you have to think about GVHD. Sometimes we end up doing biopsies, right? Because it's hard to assess why somebody has ongoing hepatitis. So, but I would say if the adenovirus is down to negative and you still have hepatitis, then there's something else that's causing the hepatitis, okay? On the other hand, we continue for several more weeks after the syndrome, the pneumonia, or the hemorrhagic cystitis, or the diarrhea, or the hepatitis, improve, because we do see rebounds if we stop early. Sometimes you have to stop early because of renal dysfunction, but we continue monitoring because there's a risk of relapse. But the short answer is, if you're still seeing ongoing or worsening hepatitis with a negative virus load for adeno, you got to look for something else.
Vikram sir, can I just quickly comment?
Please go ahead. Please go ahead, Ganesh.
So Dr. Francisco has brought out a very important point. So basically, like he said, for BK virus hemorrhagic cystitis or various respiratory symptoms, you send specific viral test. But many times we see these viral infections are multiple, like not just single virus, but it is multi-viral infections, be it BK hemorrhagic cystitis or viral respiratory infections. So this very important point I learned from my ID specialist. is quite proactive and a huge help in our practice. So many a times when one particular virus is not explaining rapid progressive downhill course for that particular patient, if you send multiple viruses and then a couple of them are positive, the one which has a worst implications, so you target with available therapeutic agents. So like BK virus hemorrhagic cystitis, patient rapidly progressing and not responding to supportive care, and if adeno is positive, you add cidofovir. Couple of patients it has happened. Apart from hemorrhagic cystitis, also respiratory pathogens. So that's a very important point Dr. Francisco has made in his previous comment. Thank you.
I mean, adenovirus is a nasty enemy. So basically, anybody with severe pneumonia, especially one thing that's interesting about adenovirus pneumonia tends to be focal. It's not like the diffuse. That's the CMV or right. So it can be very focal. Like a lobar pneumonia, people will swear is bacterial.
Okay.
And then, so any respiratory illness, any GI illness, anybody with bad diarrhea that you're suspecting GVHD, or people that you're treating for GVHD, they were getting better and they go worse. We always check for adeno in that situation. And then hemorrhagic cystitis.
That's a good point. Yeah.
And hepatitis also, for the hepatitis from adeno tends to be very fulminant in the few cases that we've seen. So it's, I don't know, in cricket you have this term that you swing, but it's too fast. It can be too fast. So.
Okay, I'm going to have to stop it here. Thank you so much, Dr. Francisco. Thank you so much again for coming on at such a short notice. I want to thank all the panelists. It was a great discussion. And I'm going to hand it back to Dr. Arvind and Keyur. And I want to thank MCure. And just a fact that you need to know that actually MCure is the sole marketing and manufacturer of Cidofovir globally. I'm not sure why it took them so long to market it in India. So that's a good question you need to answer for us, Keyur.
It's never too late. So thank you so much. Yeah.
Okay.
Thank you so much, Doctor. Till 2007, till 2018, we had never thought about it that Cidofovir has a very good acceptance in India. We have worked about and we got many requests from across India clinicians when we started focusing after mTOR launch in bone marrow transplant in India. And that's how the whole journey has started. We started working with DCGI from last 1 year, and within a year, we got the permission to market this product in India. So we have launched this product with 1/3 cost than the US price. So it is good thing for Indian patient. Now it is much more at affordable cost and the doorstep. Okay. I really thank you all panelists. I really thank you, Dr. Francisco, and the 300 doctors who has joined us to have this excellent webinar. And I hand over to my colleague Zohaib.
Yeah, thank you so much, Keyur. Most importantly, I would like to thank Dr. Vikram Mathews, sir, Dr. Francisco, and our organizing team, Mice Ideas team, and our colleagues who made this event, entire panelists who made this academic and scientific feast under the guidance of Dr. Vikram Mathews a very huge success. And I wish MCure as an organization will continue to have such scientific events in the near future, especially in the field of bone marrow transplant as well. And this is one such event which is happening. So I would just like to illustrate. And I will hand it over to you, sir. Thank you so much. Thank you so much.
Okay. Thank you. And good night, everybody. Keyur, anything else? Or shall we close?
No, sir. Thank you so much. We have next event on 23rd. No issues. Thank you.
Thank you, everyone.
Thank you.
Thank you, sir.
Thank you so much.
Everybody stay safe.
Bye.
Yes, thank you.
Bye. Bye.
Bye, sir.